So, good evening, everyone. Am I audible? Yeah. So, I'm Akshaya from the Department of Contact Lens. I'll be taking the class today. Hope the previous classes were informative and useful. So, today we'll be looking on just on the follow-up aspect, like how to do a follow-up if in case a patient is coming with the contact lens to you. So what all the questions, what all features you will ask to the patient, what all you will look on, and few things on the care and maintenance part. Like I hope that it would be covered in the last part, but I would like to just go through it once more, that what care and maintenance you will just tell the patient, the insertion removal part, the solution, how to manage everything, and few more complications, like what are the complications which we just see in day-to-day clinic, how to manage them, how to change the lens fit, or how to tackle them. Just a few insights on that. So I have just tried to cover the entire concept in one single PPT. If I have missed anything, you can just call us, or you can just come to the department. We can answer the queries at any time. So before starting, I would like to know that why aftercare is important. So we have just seen the material, we have just seen the modalities, what modality, what powers, what we have to give, everything we have just read. How to fit a contact lens, that also we have gone through. Then what is next? Then why after dispensing it's over, right? So why we need a aftercare? So why we have to go to a follow-up, aftercare, see about it? What is the need for that? So can anyone from the first row? Infections is a valid point. So it gives us that the prevention is better than cure aspect of it. But other than that, anything else why aftercare is important?
To see if the patients are handling their lens properly, are they storing it properly, are they cleaning it properly?
So you mean that we need to see the success part of the contact lens wear to the patient?
Yes.
Yeah. So yeah, going with all those points, aftercare is should be undertaken routinely just to see that prevention is better than cure. Like she said correctly, whether the patient is using the contact lens properly, whatever we have told the patient, whether they are just following it, how they are doing it, whether the protocols are being followed, we have to see that. Then next, we have to ensure that the contact lens wear is being successful. We don't like dropouts, right? So we have dispensed some lens to someone. They shouldn't be a dropout. They have to successfully continue their lens wear. So aftercare just gives you an idea how they are using and how they are handling techniques. Everything will be there. So if in case there is any discrepancy, we can still correct it and make them successful. And this includes both like subjective and the objective from our side and also from the patient side as well. So usually follow-up schedule, how we do is we call it for 3 months. Either it can be a soft or it can be a RGP lens as well. Even you can call it for 1 month follow-up where the patients can be benefited, how they are handling. Say suppose a neophyte where you have dispensed the lenses for the first time. You have taught all the lens care, insertion, removal, care and maintenance, storage techniques, everything. And then you wanted to just confirm whether the patient is doing correctly. You can call it in 1 month review also. Few challenging patients, you can call it on 15 days. The fitting techniques are little challenging. You can just recheck in 15 days so that the prevention will be better. And for RGP, usually we call it for 3 months or either 6 months. So it can be a protocol which can be maintained. So what we will do in a follow-up care? So follow-up care, first we start with the case history. We just ask the patient what lens are they wearing? Are they aware? What lenses are they wearing? What is the modality? How frequently they change it? Are they doing the care and maintenance correctly? Any difficulty in the handling techniques? And then we also go in aspects of vision. How is the vision? How is the fit? And in case of RGPs, we just check whether the RGP is popping out, whether it's displacing, how comfortable the patient is with the lens, and they sleep with the lens, whether they just wash the face with the lens. All these includes in the aftercare procedure. So with contact lens, what all we do? So we can just classify it as with contact lens and without contact lens. So as soon as the patient comes, we just go through the slit lamp and check for the abnormal signs like staining, neovascularization in terms of a long-term user, and hypoxic symptoms, any edema. And with contact lens, we just check the routine checkup like visual acuity, retinoscopy to check whether there is any power difference, and keratometry on top of the lens to check for any lens flexure or lens changes, and CL behavior. So can I just get to know like how you assess a fit? So the last class was like a fit assessment. So the newcomer could explain me the fit assessment of a soft contact lens. So the CL behavior in situ for a soft contact lens will be like centration, coverage, movement, and push-up. So push-up is positive, negative, how is the movement with blink, whether it's covering properly or not. This is a routine protocol which we follow. Then of course slit lamp biomicroscopy to check for the abnormalities, and fluorescent pattern if in case of corneal GP lens has been prescribed. So this is just a slide like under vision assessment. We just see the vision, whether it's blur, clear, patient is being very comfortable with the vision, any discrepancies. So I would just like to put some light on like when and all the patient will come with a blurry vision. So maybe the morning blurry vision which the patient says you when she comes or he comes in clinic will be due to the excess lacrimation, which upon insertion the patient will be watering and they can just tell you a blurry vision, which is pretty much normal in every patient. Other than that, if the patient is complaining of any dryness or any blurry vision, that can be due to the environmental factors where they are sitting, maybe in the AC environment or in a very windy area where their contact lens gets dried up, because of which they can end up in a blurry vision. Third thing, if the patient is not following the cleaning properly, then the deposits will get just etched up in the contact lenses, which can create a blurry vision. So assessment of contact lens is important in that case when the patient is telling a ghosty vision. And if the patient is a RGP user, just check whether the lens is centered upon the cornea well. If it's not centered, if it's decentered, again the optic zone will be in the lower part of the cornea, where the patient again complains of a blurry vision. So blurry vision doesn't mean only the power is different, it also means all these things. And if the deposits in the center, ghosty vision, foggy vision, all these come up. If all these things are not there, then we move on to the complications, whether there is corneal edema or any other difference which is creating a blurry vision. So we also do the lens verification. Lens verification, yes, practically it's not possible in soft contact lenses just to check the power of it, but we can do it in soft also. RGP lenses, we can very well check the diameter, base curve, power of the lenses. This helps us to tell whether the patient has mismatched the lenses if in case the patient is having a blurry vision. And the second thing, many patients, RGP specifically, will be using that old lenses which they have got a year back or 2 years back, so which can have a lens flexure, lens shape can change, lens fit can change, and again ending up in discomfort and improper lens fitting also. So if in case you have encounter any patient such like that, you can just take the lens, go to the lensometer and check the lens power, whether this is the same power which is correlating with whatever we have given to the patient. And these are few brochures which is available in the intranet as well. So these are the care and maintenance of soft, RGP and scleral lenses which we have. So we have the entire care and maintenance guideline which is being given in these brochures. You can just take a note of it, and you can just also have just tell the patient about the lens handling techniques. So I would like to ask, you all know how we counsel the patient regarding the handling techniques, insertion, removal, and the solution aspect and storage aspect. You all know, or I should tell? Any idea regarding that? Anything covered in last class? Any handling techniques covered in last class, like how we tell the patient to insert, remove, care, maintain? Yes? So maybe I would tell again. So initially we ask the patient to wash their hands before touching the lenses. So they have to wash their hands, then they have to make it clean with the kerchief or a tissue, then touch the lens. They shouldn't touch the lens with a wet hand. Then you have to clean the lens first with a rub and clean technique, and then you have to rinse the lens again, Then you need to insert it on eye. After removal, the same technique, you have to clean the lens with the rub and clean technique, not only the circular motion, the cross like plus manner. Then you need to clean the lens, rinse the lens again, then you need to store in the lens case. So the storage marks an important point where you need to store it in a fresh solution, not in the old solution in which you have kept it in the previous day. And one more thing, you can't top up the solution on top of the old solution. You have to throw the solution out and then you have to fill some fresh solution. And when lens is on eye, the lens case should be dry. So they have to air dry the lens case. They shouldn't fill the solution in it and keep roaming with it. So they have to keep the lens case dry and they have to air dry it, which is a better option also. And proper cleaning and disinfection is very important. If the cleaning is not good, again the deposits will come. So these all things should be taken care of. If suppose the patient is coming to your clinic with the contact lens on eye, ask the patient to remove and clean the lens in front of you and watch how they are doing it. Because of that also you can just face few issues later. So again, care and solution, you can just these are few brochures which just tell about the storage, and a few other details are like replacing the bottle caps, not to tip the bottle cap, or like not to touch the bottle cap again, like how we do in the eye drops. All these are like very important points which we have to reiterate to every patient. And some additional information in terms of traveling. If they are traveling they have to use some protective glasses. Playing sport, maybe they can wear a protective glass or a helmet and then play. And again, swimming, mainly swimming. If the patient is swimming with the lenses, they can swim, and after they come out of the water, like they need to remove and throw it off immediately, and they can't use it again. So in that case, daily disposables will be a better option which you can recommend to the patients. And engaged in any other activity like swimming or any other cases where they need to change the lens care, it has to be told to the patient as well. So till here it is the aftercare of like follow-up visits of the patients. Next we can see some information on care and maintenance. So care and maintenance, first just going through, care and maintenance is required because we need a clean lenses which gives us a good comfort, which in turn gives us a good vision, and it gives a safe lens wear. So if cleaning is not good, comfort will not be there, deposits will occur where the vision gets hampered, and with deposits or with infection, like with any unclean lenses, if we just insert, again the safe lens wear is not being there. And so this is again a brochure from University of Waterloo which just tells you about the clean hands and the habits, how to use the lens, how to use the lens case, and for storage as well. So care and maintenance has few components. It's not just the solution which we use to clean the lenses. The one bottle solution contains all these things in it. So it's a daily cleaner where we just clean the lenses and remove the dirt, and rinsing solution as well, and disinfecting solution. Any contact lenses, they have to be disinfected. And weekly protein cleaner, like if you take a monthly disposable or a yearly disposable lenses, you will be wearing the same lens throughout the year or throughout the month, where deposits can just go and embed in the lens, where we need to remove that. Specifically in terms of RGP and scleral lenses, we recommend a protein cleaner or a strong solution in weekly basis to clean the lenses also. And again, lubricating is important because the lens surface has to be smooth enough to give a good vision. If it's not smooth enough, again we end up in blurred vision also. And lens storage case is important, where lens storage also has a few interconnected techniques to the infection. So these all components have been now in modern days converted to a one single solution. These are like few solutions. The first three, the Renew and BioTrue and the Pure Moist, are for soft contact lenses, and the other two, the Boston and the Hydra Fresh, are for the corneal GP lenses, the RGP and the scleral lenses. So you two have difference in all the solutions. All the solutions are not the same. If in case some patient come to your clinic and ask, I am a contact lens user, what solution should I just go for? They show something called as Renew. Whether it's recommendable for their material, you have to know enough to recommend for them. So this Renew solution is just for an hydrogel lenses. So the hydrogel material, if in case I have to tell some examples, you have Bosch and Lomb company which gives you hydrogel material, soft lenses, and again you have few more companies which give hydrogel material also. They are like using Renew solution, it's good for them. Again, going with the silicone hydrogel material where it's hydrophilic in nature, the BioTrue and the Pure Moist will be a better option than Renew solution. So if any patient who is wearing a silicone hydrogel material, nowadays it's all silicone hydrogel, 90% are silicone hydrogel, only few amount are hydrogels. So you can recommend BioTrue solutions for all the patients. And the Boston and the Hydra Fresh which are there are for RGP and the scleral lenses. So the Boston Simplest has a little much larger viscosity, where you need to recommend some saline for the patient to again rinse the lens, or else you will get a burning sensation where the patient end up coming with a red eye. And the Hydra Fresh is very thin in nature, where they can just clean, rinse and insert it with the same solution as well. So clear enough with the solution? Any doubts regarding that? Okay, so if in case we don't follow all these things, we end up in complications. So what all the complications you have seen so far? Like some common complications you would have just seen in the OPD also. So any one or two? Can you just name any one or two complications with respect to contact lens?
Keratitis.
Okay, other than that? Keratitis is a very common complication. Other thing, anything specific? Anything commonly seen due to prolonged extended wear of lenses? Hypoxia, edema. So keratitis is there, but we don't give any extended wear in day-to-day like clinics, right? So it's like morning they insert, before sleep they remove. So extended wear, very rare cases where the patient sleeps with the lens, they get keratitis. Or else the storage is not good enough, they get. The common thing which we see is like we can classify basically it on different factors. It's not only due to the cornea structural changes alone. It's like even in vision changes there are complications which have come up. So if we take physical factors like lens fit, if the lens is loose, lens is tight, steep fit, flat fit, again cause some complications. Blinking, so improper blinking can cause dryness, discomfort, lens awareness. And lid tonicity, if the patient is having a tight lids, then they can just compress the contact lenses in the superior portion. If the patient is having a loose lids, lens will just displace, especially in the corneal GP lenses. Then visual factors like accuracy of RX, like the power is not proper, again patient end up in having a discomfort with contact lenses, which is the common symptom. And optical quality, if the lens optical quality is not good, or eye is not like the dryness or the lens wettability is poor, you end up having a complication. Physiological factors like decay by T. What is decay by T? And water content. The higher the water content is the amount of water which is there in the contact lenses. So higher the water content, the dryness will be more. And environmental, like AC environment, and blinking again. Some people like chemical, they just work in a lab or in a factory where they are exposed to some chemicals, because of which they end up in having complications. And or pre-existing ocular pathology, MGD, where we just ignore it and give a contact lens, again they come up with a blurred vision. And wearer related, yes, of course the non-compliance of the patient always goes into the complication aspect only. So I have just classified into few factors. First we can just see something related to hypoxia, where corneal edema, microcystic edema, and polymegathism and corneal vascularization are the more common things which we come up with in the clinic. Mainly the corneal vascularization, the people who are like majorly using the yearly lenses, conventional lenses, or patient with high RX power, like maybe -10, -20, -30, or in the plus side also wearing it for so long time without any break in between, all end up in corneal vascularization and some corneal hypoxic changes also, where they complain of halos after some time, especially in the scleral lens wear in post refractive surgeries or post PK or RK, where we give scleral lenses. The lenses are very comfortable, so they just wear it for 8, 9, 10 hours altogether, where they end up in saying that there are halos after I see or after I remove, or after the 8th hour I have redness. All these things comes up. And so the common management which we just do for all these hypoxic cases are like discontinuation of lens until the problem gets solved. For vascularization, maybe we can just go one step flatter, like one step loosening the lens so that the lens will move a little. There will be a tear exchange where oxygen can go to the cornea, and they can just we can prevent it from more vascularization, or to change it to high decay material. Any contact lens for that matter, soft, RGP or scleral lenses, we can shift them to the high decay material. Only one a limitation in high decay material in terms of RGPs are like they can break. When the patients are cleaning the lenses so hard, they can break, which they have to be told priorly. And second thing, when we shift someone from hydrogel to silicone hydrogel lenses, hydrogel lenses are thicker in nature. So when we just shift, they can have an hypoxic symptom which has to be told to the patient priorly. So any hypoxic symptom, any corneal vascularization you come up, just see what lens material they are using and what power they are using. So if they are using a hydrogel material, maybe we can shift them to a silicone hydrogel, first thing. Second thing, if the patient is using yearly disposable, I have seen many patients who are having -2, -3 power still using yearly disposables. For them, monthlies or bi-weeklies will be a better option than yearly disposables. We can shift like that. Or daily disposables in case of heavy corneal edema who is using for more than 14, 16 hours, daily disposables will be a better option again. So next, inflammation and infection. So if we just take this broad topic, inflammation and infection, the major things are like papillary conjunctivitis, MGD, corneal aberrations, microbial keratitis, glare, like acute red eye due to contact lens, or periphery ulcer due to contact lenses, or corneal scarring. So if we go one by one, the papillary conjunctivitis may be due to the improper cleaning, where deposits will get deposited in the contact lenses, where they come and rub with the palpebral conjunctiva and cause all these giant papillae. The patient will be asymptomatic, then slowly we can see the discomfort in the patient. One classic thing where we can find the giant papillary reaction is like, if the patient is wearing contact lenses, you can just see the movement of the lens. If they have such big papillae, the lens will move along with the lid. So when they close and open, the lens will be pulled up along with the lid as well. So then you can just see whether there are really big papillae which are just hidden inside. They have to discontinue their lens wear, and again we can shift them to a bi-weekly or daily modality, and we have to re-emphasize on cleaning as well. So the MGD part, if it's pre-existing, better to give a good cleaner for the lens so that the MGD doesn't hamper the lens surface quality. Corneal aberration, one common cause for corneal aberration, pinching the lens directly from the cornea. So removal is very important. They have to pull down and then pinch it from the sclera and not directly from the cornea. Many cases have been come because of pinching directly from the cornea, where the nails get just eroded and they aberrate the cornea as well. So that one. Then microbial keratitis, I said earlier, the lens case changing, lens case storage is really important, where again the microbes can just come up, and we have a infection. Clear acute red eye. Acute red eye again for extended wear. Patient insert the lens, sleeps overnight, they can end up in red eye. Or solution toxicity at times where the solution is not suitable for the eye, again they end up, but solution toxicity will be bilateral, so both the eye it will not be suitable. And peripheric ulcer, corneal acute red eye, all these come up because of the extended wear. Patient just sleeps with the lenses or washing face with the lenses, all these inflammatory and infection comes up. We need, like, management aspect will be, we need to stop the lens wear until the solution subsidizes. Maybe we can just give them lubricants as well, where it can be just supported, and then we can shift to different modality, and lens care should be really concentrated after getting those infections. So the next will be like inflammation and staining related complications, where you can just see the pictures, where all these pictures have been taken from the RGP user and nothing from the soft contact lenses. Maybe one conjunctival staining, the first one can be with the soft contact lenses, which is very rarely happening. Rather, the staining related, all the complications come up with the RGP lenses, where the first picture shows you the conjunctival staining, whether the lens is low riding, you can just check whether the lens is ill fitted, then you can end up having the conjunctival staining. The second picture, where you can see minute small bubbles, those are called as dimple veiling. So it can really happen in a steep fitted contact lenses, where a bubble trap can happen, which can just go and stain the cornea all over. And third, corneal staining, and fourth will be 3 and 9 staining, especially in the RGP cases with keratoconus. When the fit is like really tight in the 3 and 9 o'clock, we just see the 3 and 9 staining. For all these things, we need to play with the lens fit. We have to remove, and then we need to do a retrial and then come up with the new fit. So next will be the lens and lens fit related complications. So the first picture, as you can see, how is the lens? Can anyone tell me? So the lens is really up, it's not staying in the cornea. And the second picture, the lens is down. So these are like classic flat fitted lenses. So these can be like giving you a really disturbance in the vision, where the optic zone will not at all cover the entire pupil. And again, when the patient looks up, looks down, patient will be having distortions in vision. So these kind of fitting, we have to fit with a proper base curve, where we need to steepen it. And the second picture, we can see a staining in the superior part, which is called a seal. So arcuate lesion, epithelial arcuate lesion in the superior part. This can happen when the patient is having tight lids. So better we can shift them to the RGP lenses than the soft lenses, where the movement will be better. The third one is the solution toxicity. Like I said, the solution, if it's not suiting, redness can happen, where we need to shift to a better solution for the patient. And the fifth picture is the lens case, which is terribly in a bad condition. This can give you a lot of infection. So whenever patient comes, ask them to take all the lens case, solution, whatever they have, just show it to you. So you can just find out how they are maintaining their lens case. Even some patients, they have a box where they keep the lens case. That box even will be dirty. There will be dirt all around, and we need to change the box itself. So we have to really look on to all these points, not only the lens fit alone. Then the sixth one will be the lens deposit. Again, improper cleaning, which can cause the lens deposit. And the seventh one is the mucin ball, where the deposits just come and just settle in the contact lenses. You see some ball kind of thing. All these are related to the deposit kind of complication. So cleaning again will be re-emphasized, and maybe we can shift them to RGP lenses if deposits are more. And lens storage, if the lens storage is not proper, better counsel them with the daily disposable lenses. So this is something to do with the mechanical pressure, where the lens adherence This is a classic sign of an RGP lens which has been superiorly ridered, and we can see the lens imprint on the cornea. So this can be a tight fitted lens where the mid peripheral area will be just pressing on the cornea. After removal, if you stain, you can see a staining and a corneal binding also, where you need to shift to a scleral lenses, or else you need to loosen the fit again. And corneal warpage, which can happen due to a long exposure to a same lens. Corneal shape changes can occur again. Ptosis. So any idea like why ptosis is a complication in a contact lens wear? It shouldn't be a complication to a contact lens, right? So why ptosis is a complication? Any idea? Any guesses? So you can think mainly in RGP. So I will also give the clue. In RGP, ptosis will be a complication. Patient will be having a good palpebral fissure. They'll be looking very good. But as soon as they are a prolonged user of corneal RGP lenses, they will have a ptosis kind of, maybe we'll say ptosis kind of appearance than a ptosis. Can you think of the lens comfort and the complication? Do you want to tell something? Okay. Before you were telling something, no? Okay, so usually how a RGP lenses feel on eye. So hard material placed upon the cornea. So you have a irritation. Patient almost goes like squinting, and that a prolonged user will just grasp that, and it will be habituated to him, where he will always have a ptosis kind of appearance whenever he comes because of the irritation. Again, if the patient if the lens is also ill fitted, where there is a lift in the lens, again the patient will be like, due to irritation, he will be squinting his eyes, making a ptosis appearance, which can in turn cause a discomfort. So finally, the vision problems are very common, so that will be a larger complication than all these things. Vision is not good, but back of the vision, all these things will be there. First thing, changes in refraction can be one thing. If it is not good, again changes in refraction can occur. A steep fit can give you a high minus, and a flat fit can give you a high plus. Again, fitting you need to correlate. Or a residual refractive error in case of toric contact lenses, soft toric lenses. If the lenses are rotating, you will have a discrepancy, and you will get residual refractive errors, which again have a blurred vision. So other than that, some deposits, poor wettability, all these come in vision related complications as well. So where the blurred vision will be the first point which patient comes and tells you. So that's it for the complications. These are the major complications which we just see. So we have to just remember one thing: whenever patient comes, we have to tell them to clean, rinse, and have a proper storage of lenses, not to sleep with the lens, and not to wash their face with the lens. Swimming, yes, if it's a hobby, they can very well do it with the contact lens. They can come and remove and throw it off. So these are few complications which we encounter day in and day out, and this is how we manage them. Other than that, any doubts you have, you can just ask me. So I'm done with the presentation.